Unlike a lot of younger patients, older patients with cancer frequently come in with other problems, what we call comorbidity. So in addition to the cancer that they've now been found to have, they have things like diabetes, heart disease, arthritis. So the challenge is trying to give the best quality cancer care in context of a lot of other serious illnesses. Don't ask the age of the patient. That shouldn't be the first question. When you get the age of the patient, you need to say, how long can we predict this patient will live? You know, if they walked in today and they're healthy in 78 and 80. And frequently, it's 5, 10, 15 years. And so a treatment that's very, very excellent may be not given to that patient because of the misperception that they don't have a lot of good life left. I think there are two concerns we always have with older people. One is undertreatment, and one is overtreatment of the patient. Maintaining function and quality of life is most important in older patients. A little bit of nerve damage with a chemotherapy drug in a younger person that might just give them a little numbness and tingling, in an older person might make them prone to falls or might put them from living independently into a dependent living situation. So a lot of those issues are a concern, and I think what we can offer is factoring out issues like that, figuring out how the treatment might affect those issues, and helping that doctor make the best decision working with the patient. We have a wonderful registry trial which uses what's called the geriatric assessment, which we have computerized and which we're offering to all patients, which asks questions about their lifestyle. Can they go to market? Can they shop? Can they drive? Can they pay their bills? How many falls have they had in the last month? To assess them. These are integral data that we know if we find problems, we can intervene and make patients' lives better and perhaps longer. Dr. Sharpless is really one of the stars, I think, of our cancer center, and he is an expert on molecular markers of aging. And what that means is he is looking at genes that change with age. And he's excited about a gene called P16. What this gene may tell us is what's our body reserve in all our organs. And also looking at people as we see them initially for their cancer treatment to see if people who have a high level of this gene expression, so that would be bad. It would tell us their body cells can't divide as quickly. If they're not going to do as well as people who have very low levels. We would love to see these patients and put them on trials here. I think the key is changing a little bit of the age bias, which still lingers in the community. If you were 65 or older, only 1 out of 3 patients got offered a trial. If you were less than 65, it was half. By the way, we weren't thrilled about that because these were centers where every patient was potentially eligible for a trial. But if you offered the trial to the patient, whether you were older or younger, the acceptance rate was about 50%. I enjoy the patient interaction, trying to get patients on our trials, and hearing the stories about older people. But I find that's the most enjoyable thing I do.